Yeah, welcome to the dialogues. How are you?
Good, good. How are yourself?
Yeah, good, good. It's really great to have you. I'm really excited actually, and I think that this is one of the episodes that I've been most looking forward to. I'll
Great.
get you to introduce yourself in a second, but the reason I'm particularly excited is because you're an endocrinologist, and I think that it's interesting that as a diabetic and being in the community of diabetics, we talk a lot amongst ourselves. I
Hmm.
think it's rare. Well, it's rare, at least from where I've sat anyway, that we actually get a chance to hear from an endocrinologist and understand the perspective of an endocrinologist. So I'm really excited to have you on today. And
Great.
in
No.
saying all of that, if you don't mind, just a quick intro. Tell us about sort of who you are and what your background is.
Sure, sure. Yeah. Well, first of all, thanks for having me. I'm really excited to kind of chat and share my perspectives and experiences with you today. So a little background. My name is Dr. Calvin Wu, by the way. I am an endocrinologist based in San Francisco, California, and I'm currently the lead endocrinologist at Steady Health. So maybe that requires a little context as well. But Steady Health is a completely virtual diabetes clinic that's basically available on your smartphone. We're currently in California and Washington State in the United States. But I guess importantly, we are first and foremost a full service endocrinology clinic. So we see patients via telemedicine visits, we write prescriptions, manage labs and paperwork. What sets us apart though, I'd say, is that we go above and beyond. We were leveraging the power of continuous glucose monitors to provide us a constant flow of data so we can, troubleshoot and deal with issues as they arise. And we're using software then, messaging, video, telemedicine, et cetera, to deliver more data-driven, connected, and personalized diabetes care experience overall. So I
Awesome.
think we're really solving for a couple things. I mean, I think lack of access to providers, diabetes being a 24/7 disease, and kind of lack of time to review the data and really use that to personalize diabetes management.
Yeah, look, I think Steady Health's a fascinating organization, and really keen to sort of unpick a little bit about how Steady is addressing some of the issues that exist, I suppose, in the world of diabetes and endocrinology. Before we kind of jump in, I think to get a bit more detail around Steady and this new model of care that you're bringing to the market, I'd love to hear a little bit about your journey as an endocrinologist. Tell us a little bit about how you started and why you got into endocrinology.
Sure, absolutely, absolutely. I think if we want to talk about the path of how I got to where I am today, it probably starts in college. So I studied bioengineering at UC Berkeley. I'm really always really been fascinated with technology itself, and particularly applications in health and healthcare. Right. I really enjoyed that stint there, but I would say I was definitely drawn to kind of the human interaction. Really enjoy kind of working with people, pushing them on this path towards better health and so forth. So that kind of made my decision to go into medical school. Went to USC, University of Southern California. Medical school is kind of it's actually, it's 4 years, which, in some ways sounds like a lot, but it's also a lot of material to cram into a couple of
Yeah.
years. I will say that, endocrinology in terms of its, the topic itself always kind of, piqued my interest a little bit more than the rest. And I think it has to do more with kind of the elegance of the hormone pathways that our body has and so forth. It's just really nice that you can actually make sense of things. And so that really drew me to that field in particular.
When you say
Um,
when you say make sense
yeah,
of things, give us a little bit
yeah,
more detail. I think I find this stuff fascinating, and I think our listeners will find it fascinating as well. Just to kind of,
sure.
because I think it's easy to think about an endocrinologist as someone helps you deal with your diabetes, but I think there's
Sure.
so much, so much more to endocrinology, and when you say that endocrinology allows you to get a sense of things, give us a bit more detail on that.
Yeah, yeah. I mean, to be clear too, I think obviously every endocrinologist has a different experience, but I'd say, when I was out in practice and so forth, I was probably saying 40-50% diabetes actually. So that leaves a good chunk too that's seeing other things like thyroid conditions, adrenal glands, osteoporosis, etc. So
Yeah.
there's a whole field outside that, but coming back to the question in terms of endocrinology and so forth, yeah, I think that in terms of what's really fascinating about it is that it's really about communication, right? Your body's different organs are basically communicating with each other. They're coordinating things. And what's really cool about endocrinology is that if you understand those signals and what they're intended to do, you
Yeah.
can diagnose the problem from there, right? So maybe I can give a simple example, which is to say, if you think of your thyroid as a hormone factory, right? It's just making hormones, thyroid hormone, I should say. Well, to be clear, there's a part of your brain that's controlling that, sending hormones, and if those levels rise, it basically says, thyroid, make more hormone for me, right?
Mm-hmm.
So if you're diagnosing a problem with the thyroid and so forth, you then look at those hormone levels, the TSH in particular. You're saying, oh, if the TSH is high, it means my brain is really trying to push my thyroid to work harder. So actually the problem then lies in your thyroid. Your thyroid factory is destroyed, essentially. It's not producing enough, for instance. But if those hormone levels are low, maybe something's upstream is the problem, actually. Something in your brain is not sending the right signals. So hopefully that gives you a taste of kind of how interesting it all can be. And it all makes sense at the end of the day. You can figure out where the problem is based on that.
Do you want to even delve a bit deeper? Because I think this stuff's fascinating. Do you want to delve a little bit deeper even into sort of hormones in general and kind of give us a little bit of context about the importance of hormones? Because that's really, I suppose, what you're dealing with as an endocrinologist. That's kind of, you're a hormone doctor. Is that
right? Exactly.
is that
exactly
a way of looking at it?
Yeah, no, and it's at its core, yes, we are hormone doctors. I think that's a fair statement in that case. And I think hormones truly are really chemicals essentially that help us coordinate our activities. So the sense is that your body is always trying to maintain homeostasis, right? We don't want too much of anything. We want too little of everything. So in that regard, you're always trying to stay in between in that sweet spot, we'll say. So when it comes to hormones, then exactly, you're just trying to coordinate those things. So for instance, your blood sugar doesn't get too high. Your body temperature doesn't get too high, for instance. All those are all driven essentially by hormones.
And so there's probably a really long list of conditions that we could go into that are relevant to hormones, right?
Sure. Yeah, exactly.
I imagine that actually you overlap with other specialties quite a lot. And that other specialties may even come to you for consults to help understand things when hormones are at play. But if we take diabetes as an example, because I guess that's one of the more prominent hormonal conditions, and I suppose we don't always think about diabetes as a hormonal, because I think we kind of we live in this world of we've got diabetes and we manage it and it's all about blood sugars. But actually, do you want to give us a bit of context around the relevance of hormones in the diabetes space?
Yeah, no, I think this is a very relevant question because I think when we talk about diabetes, it's always like, oh, high blood sugar, low blood sugar. But it's important to understand at its core, actually, insulin is a hormone that regulates energy, right? It's how our bodies actually make use of energy properly. So to give you some example there, like as you eat something, right? You eat something, you absorb those nutrients, those amino acids, those the glucose molecules making your bloodstream. They're circulating to get to your cells, right? So insulin then is a hormone then that basically says, open up those doors, let this sugar into your cells. And then once it's in there, use those to make other new molecules, new cells, new things in other lives. Maybe store some of that extra sugar for later, for instance, right? So in other words, it's coordinating all of that. And so if you look at, for instance, when you're eating, when you're fasting, those hormones are also constantly changing. Because if you're eating, for instance, you're in a well-fed state, there's plenty of nutrients, that's where insulin's active, actually. Right? It's actually trying to put those into use and store them away. Versus if you're hungry and you're starving, for instance, insulin levels are at the lowest, right? Because you're not trying to do that anymore. You're trying to actually, kind of derive energy sources from elsewhere. So.
And so, do you want to give us a little bit more detail around insulin itself? I think you did explain it pretty well in that it's like a key that unlocks the cell and allows it to function. Where do things start going wrong? And I suppose we could go down two paths here, and I'm curious probably to unpick the type 1 and type 2 and other types as well, because I know that there's a growing list of different types of diabetes. Do you, and one of the things I think that we're all fascinated by, particularly type 1s, is how did we get it? And certainly I know me, I reflect on my diabetes journey. I was 30 at the time when I got diagnosed with diabetes, and I look back in that time, and I was working particularly hard, and I wonder if it was stress related. But I'm always going to wonder, because it could have been a virus, it could have been stress. I mean, do you want to help me and help our listeners kind of, I don't know, begin to get a bit of a handle on how we might think about how we ended up with type 1?
Yeah, I'll try to answer that, which is to
Yeah,
say
it's a
the
big
answer is
question.
complicated, and we don't know all the answers actually. So
Yeah, that's
to be
challenging.
clear, I think let me preface it by saying that first. But
Yeah,
in terms of diabetes, again, because the manifestation we're familiar with is blood sugar, but again, it's at its core actually all of diabetes, and you're absolutely right by the way. Diabetes is a hodgepodge of the different diseases that manifest in similar ways, we'll say, with it being a high blood sugar or otherwise. But at its core, in other words, it's really about insulin actually. So when you talk about type 1 and type 2, and obviously I'm generalizing a little here and simplifying of sorts, but basically it comes down to, is there insulin around, right? So is there a true insulin deficiency, right? And this gets to type 1 diabetes. And type 2 then is going to be more insulin resistance, which means you make insulin, but it's nowhere near enough to meet the demand, right? Supply doesn't meet demand essentially.
Mm.
And you can actually have kind of in-betweens, which is to say you can have people have type 1 who have elements of insulin resistance, for instance.
Mhm.
So they're reliant on insulin, but they may require much higher doses than someone who doesn't have the insulin resistance as well. But
Yeah.
at its core, again, either insulin isn't there or it's not working properly.
And so that's interesting actually about type 1s having insulin resistance as well. Does that mean that you have type 1s who have versions of type 2 or?
Not so much so. I think in those, I want to be clear that type 1, the reason they're having those issues is, again, their pancreas isn't producing insulin per se, but in other words, they can have elements of insulin resistance. That, for instance, being overweight, for instance, is one of the classic situations where you're gonna, that counteracts how well insulin works. And
Yeah.
therefore they can require just as much insulin as someone who has type 2, who typically needs
Yeah.
much higher doses, we'll say.
And so how do we start to unpick the origins of our getting type 1 diabetes? And I know that there's a lot of,
Yeah,
that we don't know, but
exactly.
like, is there any comfort we can take in kind of thinking about some of the potential reasons that we have type 1 diabetes?
Well, we have mapped out that it's likely an autoimmune process, right? So we know your immune system has somehow along the lines gone haywire. It's recognizing your own pancreas essentially as the enemy and gradually destroying it. And so, if those factory cells, in other words, are destroyed, you're not making insulin. In terms of causes, there's, stress, for instance, like things like, infections, for instance, but
Yeah.
anything that really turns on the immune system is really thought of as a possible culprit, unfortunately, right?
Yeah.
So this is where, unfortunately, I can't give you a straight answer, which is say, how did it happen in you? Which is to say, we're still looking into that. There's clinical trials, for instance, that are trying to understand and pick apart that knowledge, but unfortunately, we don't know exactly. So there's a lot of conjecture here, but we do know that there are certain things that seem to precipitate it, right? And so even viral infections, for instance, in stressful situations, etc. But
Yeah.
at the end of the day, how it manifests is an autoimmune attack, in other words.
So let's say we were to say stress is a cause. How does stress per se initiate the autoimmune response? And actually, just on that,
Yeah,
is there any
yeah.
type 1 that's not autoimmune?
To be clear, type 1, so technically it wouldn't be called type 1 if it was something else. So there's actually there's another class called secondary diabetes, which means it's due to a different disease. Let's say, for instance, you have cystic fibrosis, right? Where there's all these secretions that clog up the pancreas and it ends up kind of digesting itself. That's a different situation because the pancreas itself is damaged, right? So it's not an autoimmune attack in that situation. Alternatively, let's say you have pancreatic cancer and you end up taking the whole thing out from surgery. You don't have those cells anymore, but it's not that you have type 1. However, functionally speaking, you have the same problem, right? Which is to say that you still need to treat with insulin because your body doesn't have that capacity. Does that make sense?
Yeah, it makes sense. And so stress, how do we implicate stress? Like what does stress do that creates an autoimmune response?
I'm not an expert on that, I'll be clear. I think there's a lot of complicated pathways that people are still exploring.
Yeah.
And so I think it's not clear. I think
Sorry to
it's
put you on
a
the
simple
spot
answer.
with that one.
Yeah, no. I've read into some of these things, but it's hard to really explain. And I don't think we have a good firm understanding, I think is the key. So.
Yeah, and that's interesting. So, and I suppose it's probably a similar answer to viral related or any other thing that triggers, autoimmune responses. In terms of the research and in terms of the research that you would have seen as a student and where we're at with the research now, where do you think we are at in terms of getting closer to preventing type 1. I heard something about potential vaccines or potential treatment to avoid type 1. Have you got any?
There's research in that area. I would, the best way I'd characterize it right now is it's pretty exploratory, which is to say that, that we're basically trying to temper that immune response and, make it so that our immune system doesn't attack our body and so forth. There may be some small encouraging, results here and there, but it's nowhere near ready for prime time, we'll say.
What are you seeing in the worlds of diabetes research that's encouraging at the moment?
I think if you're trying to address it from a biological standpoint and so forth, I think one of the interesting avenues is like islet cell transplants, right? For instance, like the idea here is that you can, extract these islet cells, actually infuse it into the liver, and those cells, if they take and so forth, can essentially produce insulin appropriately. So you have some people, for instance, with type 1, I've seen a small number who have even, been off insulin for some time. The questions, of course, is, long term, what is the outcome, right? In terms of the procedure itself, in terms of, does that insulin independence, we'll say, kind of persist? That's the challenge, I think, and it's still, again, also very experimental at this stage.
So you're saying that currently there are type 1 diabetics out there who have received islet cells, injected islet cells, and
Exactly.
that they are functioning and producing insulin in those patients, and and so there's some patients who are not on insulin because of those injections or transplants?
Correct to some extent, exactly. So, but then again, I've had people, for instance, where, like for instance, 1 or 2 years later, they're back on insulin, for instance. So the question here is to prolong that longevity of those cells, to also, and getting these cells is also hard. For instance, a lot of times it's from a cadaver, someone who's passed away, taking those cells immediately, and those whole protocols are very complicated and still in development. So, but that's promising, right? If someday we could somehow generate stem cells that we can put into the body and they take and start producing insulin, that'd be amazing, right? That would be kind of like the holy grail, we'll say.
Yeah, I think that's a fascinating topic and a potentially exciting topic as well, because it looks like a real practical way to solve a short-term problem anyway. Who are the patients getting those transplants at the moment?
It's very selective, and again, these are clinical trials, to be clear. So it's not that any center is saying that, oh, we're open up, everyone who has type 1 diabetes, please come to us and sorts. I think a lot of it's in medicine. There's a lot about risk versus benefit, right? Which is to say, going through this procedure, there are risks involved. Is this someone who's likely to benefit? Like, for instance, someone who's having a lot of lows, very sensitive to tiny amounts of insulin, for instance, they might benefit tremendously from this, for instance. And so, and potentially someone younger, right? They have more years to live, we'll say. It may be more helpful for them to kind of prevent these outcomes. Again, I'm not on these selection committees to decide which patients are, but for instance, those could be good reasons to select someone to undergo this route.
It is really exciting. What other areas of research are you seeing that you think is worth mentioning today, and for our listeners to just to be aware of?
Yeah, I think the other thing, so I mentioned kind of approaching this from a biological angle. The other angle is actually approaching this from a, we'll say, bionic angle, right? Yeah. So basically trying to use technology, in other words, to kind of mimic the pancreas and hopefully also create the artificial pancreas, right? Yeah. So that someone could literally plug into a machine essentially and have all that happen and so forth. I mean, we've made a lot of progress, I'd say, even the last, we'll say, 5-10 years and so forth, and there's a lot of promising things coming down the pipeline, really. I think if you think about that realm, by the way, there's this concept of a true closed loop system. So which is to say that you have a CGM, so you have at least some source of data, in other words, right? Yeah. So it's a continuous data of your glucose levels. Then you have an algorithm, some sort of thing to basically process those numbers, understand where things are going. And then you have a pump, basically delivering insulin and maybe other hormones too, actually. Yeah. Right, and then if these are all in constant crosstalk and so forth, and coordinating everything appropriately, then maybe someday we would have something that could be very responsive, manage your blood sugars when they go high, when they go low, and they would adjust your insulin levels accordingly, right? So in that realm, for instance, just so you know, there's right now, at least in the United States, there's 4 major CGM brands. There's close to 40 CGMs in development right now. So I think in the coming years, hopefully many of those will come out to be real products, and so that's very exciting, you know. And then from the pump standpoint too, there's multiple pumps as well that are in development now. You know, I mentioned kind of different hormones. Like there's one, for instance, that actually will include insulin and glucagon, right? So up until now, for instance, traditional pumps actually only do insulin, so you can only lower blood sugars. But if
Yeah.
you give too much, it's given. You can't really do anything about that.
Yeah.
Imagine then being able to apply the brakes and give glucagon in reverse to raise your blood sugars, right? That's very cool, right?
Makes a lot of sense, doesn't it, actually, just in practical
Mhm.
terms, that you would have a device that actually is able to go both ways.
Exactly, because right now we only have a brake pedal essentially, and we can only go down, right? And so to be able to have control in both directions would be incredibly exciting.
How do pumps manage that at the moment? Because you don't,
Mhm.
and maybe it's the way that pumps are sold, but you don't hear when pumps are mentioned, I don't hear that hypos are a problem. What's the kind of general messaging from the pump companies as to why hypos aren't an issue? Or are they?
I think it speaks, yeah, I think it speaks more to the CGM and kind of predictive algorithms there, which is to say that it's basically now that, you know, now that we can kind of understand the trajectory of your more recent blood sugar readings, is like, where do I expect things to go, right? Because, you know, if you're rising and so forth, the assumption is you'll continue rising. But as it gets more data, it's going to update its algorithm to say that, yeah, my prediction actually is changing over time, right? And so that then allows your pump then to kind of preempt it, right? Say like, oh, I think my blood sugar is going to drop to 70, for instance. I'm actually going to start taking away my basal. You know, stop releasing that constant release and so forth, so that by the time you actually get there, I've already changed course, right? I've given you less insulin. Your blood sugar is on its rise now, essentially.
And um, is there evidence around number of hypos for people with pumps versus people without pumps? I mean, what do you expect there? What's the data say?
Yeah, I mean, the truth is we have currently 2 hybrid closed loop systems on the market, and again, many more that are in development. And that's actually one thing they're trying to prove, which is to say, you know, especially now that we have CGM and so forth, you know, time and range, right? Trying to keep your blood sugars between, well, we use different metrics here. We use milligrams per deciliter, 70 to 180, for instance. But the idea is if you keep people in that safe zone and so forth, how much can we maximize that, but also avoid the low blood sugars, right?
Yeah.
And so a lot of these trials are also trying to look into that to say that, you know, there's a reduction there, that we're managing to, because of these advanced algorithms and trying to take away the basal or when it's necessary, it can hopefully prevent those situations. So if you look at some of these trials, for instance, you'll see some encouraging data in that direction.
So just to change tack a little bit, I'm quite curious and keen to start to explore, you know, models of care and the system in general that we are all in this healthcare system and endocrinology in general, and the sort of dynamics that influence patient care and experience. So yeah, do you want to just start to kick off a little bit? And I don't know whether growing up as a junior doctor, you know, there was lots of kind of thought given to system issues, you know, in terms of the system that we're all in as patients and doctors. But do you want to maybe speak a little bit to what you've seen or how you've seen the system, the healthcare delivery system evolve over the last however many years? How many years has it been since how long ago were you a junior doctor?
It's a long path for us. Let's see here. So 4 years of residency. I did 4 years because I did actually internal medicine and pediatrics. So that's another 4 years plus 2 more years of fellowship. So
Okay.
we'll say 10 years in training, we'll say. And then came out, I've been about, I'll say 4 or 5 years out in practice now. So.
And yeah, so maybe give us a little bit of insight into, you know, your perspective as a doctor to the system, you know, and what you've
Yeah.
seen. You know, has it changed over the last X number of years, and what sort of changes have you seen, if so?
In short, not much. And so maybe to preface that a little bit is to say that, you know, like I think as we're training and so forth, I think a lot of us come into medicine with kind of an ideal, an expected, you know, we know what we're getting into sort of, but we don't really know the day in and day out kind of nuts and bolts of all of it. I think when we come out and so forth, we don't really get trained on how, like, you know, how does billing work? How does the healthcare system work and so forth? So in some ways, I think we're all in for a rude awakening when we, you know, start practicing and seeing patients, because the reality is, unfortunately, a lot of medicine is actually spent on paperwork. So a lot of times it's spent on, like not having enough time, because you're scrunched in to see lots of patients, especially if you're in a large managed care type of like organizations, for instance, where unfortunately, or it can often feel like you're just a cog in the wheel, like you're just seeing tons of patients, etc. And then on top of that, you have to also worry about kind of reimbursement. It sounds sad, but the truth is, at the end of the day, it's a business as well, and you have to kind of keep things going of sorts, right? So you have to kind of look at how much are you getting paid for this and so forth. I think a lot of people have this conception that doctors are paid well and so forth, and there's no doubt that there's some that are. But I will say that the system actually is much more complicated than people realize. And for that matter, the cut, we'll say, that we get is actually potentially much smaller than people understand as well.
Absolutely. I don't know what it was I was listening to. It was in the last day or two, and it was actually talking about the business of healthcare, and we could probably do an entire podcast, actually, I think. And it's certainly an area of interest of mine, being in Australia, having lived in the UK and in the US, and having been exposed to systems and having awareness, and having worked previously around the space of healthcare delivery, and being aware of efficiencies and inefficiencies in systems, and looking at the US, for example, and seeing how inefficient it is as a healthcare delivery model. And not just that it's inefficient, it's one of the... So where I was going with that was, on one hand, you've got the US system, which is expensive, but the outcomes aren't any better. And in fact, some of the outcomes are outside of, say, the top 10. So you've got the most expensive system, which actually isn't delivering the best outcomes, which must be really frustrating. And then you have, it's frustrating as a doctor and frustrating as a patient as well, particularly as a patient.
Exactly.
And then you've got all the businesses around it, the insurance and just the private hospitals that have these executives that are getting paid pretty well.
Yeah, exactly.
And we're not going to solve that problem today, but I think it's good for everyone to be aware, because I think sometimes I certainly hear patients, and I've probably been one of those patients, that complain about sitting across from an endocrinologist who didn't give me what I wanted in that interaction.
Absolutely.
So I've kind of covered a lot there about the US system, but do you want to, I don't know, do you have, what are your thoughts on that system, on the inefficiencies and the outcomes that are, they're in the US at the moment?
Yeah, well, I think a lot of topics there that I think fully agree with, of sorts. And it's to say that, I think at its core, healthcare should just be provider to patient, right? If you think about it, those are the two stakeholders in this conversation that matter the most, right? The problem there is that there's a lot of people in between that kind of put themselves into place of sorts and are involved in that interaction of sorts. And so that's what's probably most frustrating, is that, like, for instance, I'm very familiar with the patient side as well. I've seen my family members kind of go through it too. So you'll get these surprise bills, it just feels sometimes like you're being nickel and dime and so forth. I completely understand it too. And I think maybe since that is probably a common experience, maybe I'll shed more light on the provider side. It's the fact that, for instance, I think healthcare is one of the very few industries, for instance, where you get a product and you don't get paid for months on end, by the way. So for instance, when I bill an insurance company for a visit, I actually don't get paid for 2-3 months sometimes, actually. It can be that long, actually. That's true with Medicare. That's true with, a lot of health insurance, maybe a month, we'll say, but at the very least, you don't get, it's not like a, quick transaction. So, and then on top of that, then they'll come back and say like, oh, you didn't document this. We're going to deduct some money from this because it didn't qualify for this visit, for instance. And then, sometimes like, let's say someone gave you the wrong credit card number, like a honest mistake, for instance. But when you bill them and so forth, it doesn't go through and so forth. And then you can't find them, for instance. Then you don't get paid either, right? So it's frustrating for both ends, but the system's definitely broken in many ways. And again, I think it speaks to, again, that there's just so much stuff crammed in the middle that doesn't need to be there, right? Like, like in terms of price transparency, for instance, is a huge issue. Like the fact that I don't know when I prescribe a medication how much my patient will pay for it, and to even compare between options, it's very hard to do so. I mean, there are fortunately some initiatives towards that direction, but like for instance, like GoodRx, for instance, you can actually look things up and so forth and compare costs of sorts. But even then, there's pharmacy benefit managers, etc., making deals on the back end there to even allow for that. So the problem is, again, that there's a lot that's being intervening, but we don't see it at the end of the day. All we see is this interaction being poor, and then we blame each other essentially.
Yeah.
So
Yeah. And look, I think it is, as I said, a fascinating topic, and we could spend quite a while on it. This one's putting you on the spot a little bit, maybe.
no,
Do
sure,
you, and it's just out of my pure curiosity, actually, because I
please.
talk about it a little bit, and that is how did, and we are talking about the US, right? And you know,
Yeah,
I probably need to explore other systems with some other guests, but how
sure.
did the US healthcare system end up? Where do you have any insight into or any kind of knowledge as to how it ended up? Just out of curiosity, how it ended up where it is?
I have some sense. I mean, the truth is, again, unfortunately, we don't have much of a training in this, and we really should, because to
Yeah,
understand how we got here is part of the issue, right? You have to understand how we got here before we can try to fix this mess. I mean, for one thing, for instance, insurance is often tied to jobs, right? Health insurance and so forth. And so, for instance, if you lose your job, you lose your health care, and it's like, well, okay, like I didn't lose my job on purpose a lot of times, especially in COVID right now, right, where people are losing jobs just because things aren't working out for anyone really involved.
yeah,
And so I think that's certainly a big issue here, which
yeah,
is to say that things are tied to the wrong. There's no incentive there really, right? Like
yeah,
I'm not. I don't want to lose my health insurance, right? But
yeah.
it's kind of to that and so forth. And then on top of that, I think in the back and so forth, I'm not sure how we got to all the hidden prices and otherwise too. But there's certainly just way too much bureaucracy, kind of that's kind of been insurance companies, for instance. Like I think when you think about health insurance, that's at its core again
Yeah,
should be something you only use when in an emergency, right?
yeah,
But health insurance is something, ironically, that's applied whenever you see a doctor, et cetera. And
yeah.
there's this whole business of out of pocket, for instance. It's super complicated, right?
It's
Like
super complicated. Yeah,
it doesn't need to be. And but then with so many different players involved, without any true transparency in what's going on, I think that speaks to the issue here that we're having in the United States.
well, yeah, we know what's going on. I mean, there's cash incentive to deliver
Mhm,
healthcare, and if there's no cash
exactly.
in it, they won't deliver it. And so, that's that's the beginning of a massive problem for people who are suffering. You know,
Maybe a not well known point, by the way, is that we're not, even as doctors, we're not allowed to know how much else someone else is paid on that contract. Actually, it's illegal apparently.
yeah, yeah,
So for instance, we can't even say, oh yeah, how much are you charging for a patient and so forth. And if I were to ask and you find out and so forth, that would be against the law.
yeah,
It's ridiculous. Like I mean, it really should be that a procedure costs this much.
yeah.
Maybe you charge a little bit because you provide a better service or whatever, but it should be out there, but you don't know that. You can go to one hospital and be charged twice as much as another. So
And so we could spend another podcast talking
yeah,
about capitalism and so on and so
exactly.
forth, right? But is there any reason to be optimistic about US healthcare system? Is it possible that we may see in the next 50 years a system that's fairer?
I hope so. I truly do hope so. I mean, the truth is in healthcare, things move very slowly.
Yeah,
And I think it's because there's so many stakeholders involved of sorts. But, for better or for worse, I think the pandemic's really, laid bare really some of the flaws in the system, especially when people are losing coverage and have no place to turn.
yeah,
Right. I think so in that regard, necessity really will drive this conversation, I think, which is to say that when we have tons of people who can't manage on their own, when we're seeing bad outcomes,
yeah.
I truly hope that the lawmakers, that everyone involved can come together and find a solution. So I'm hopeful for that, but I
Fingers
haven't
crossed
been very
for
impressed with the progress so far. So
fingers crossed for some better leadership, I suppose,
yeah,
in many senses, but in the healthcare delivery sense in particular.
correct.
So look, this does segue, I think, fairly nicely because I think Steady Health is probably battling in a number of fronts, right? So
Hmm.
the way I see it, Steady Health is trying to deliver better healthcare for diabetics,
Hmm.
number
Absolutely.
one,
Absolutely.
and you're doing it in this system, and I suppose that probably does create some obstacles.
Hmm. Absolutely.
Do you want to talk a little bit about the improvements that Steady Health is looking to bring to diabetics through this new model of care?
Absolutely, absolutely. I think just to be clear too, I think my motivations for joining Steady were actually twofold. I think the patient experience needs to improve, but I actually think the provider experience needs to improve too. And
Yeah,
so that was really one of my main motivations to join Steady and be part of this whole movement of sorts. So I think what I love about Steady, I think I really love the deeper connections I'm building with my members because it had a say in kind of how we design our care model. I can say that our first visit is an hour. I can say that we can continue this conversation over messaging. and I can spend time on mental health because I have the time to do so,
Yeah.
and like the fact that we can spend a whole hour talking about data, that's unheard of in a traditional healthcare experience, and that's
Yeah.
very fulfilling for both of us because at the end of the day, I think as doctors, we're part-time advisor, we're part-time kind of translator actually, because it's like we have all this medical training and so forth. We want to translate and distill it down to its core elements to present to a patient.
Yeah.
And we're and more and more, I think in the past, medicine took a very paternalistic approach to this and said, oh, you see a doctor, here's a medication, take it and be good, etc. Whereas now I'm very happy to see that there's a movement towards shared decision making, for instance. And this is very much in that line, right? Which is to say that we want to help you understand what's going on, because that's how we move forward together. Because at the end of the day, diabetes is a disease that the patient manages 24/7, essentially, right? We're there for a tiny sliver of that time. But as much as we want to, as much as we can, I should say, is that we want those interactions to be meaningful. So being able to spend this time, for instance, with the data has let me figure out that a lot of times it's not just the ratio. It's things like the meal composition. It's how they're timing their boluses, for instance. I've actually been able to carb count with people, for instance, too, and then we can identify when things are a little off, etc., and kind of change course. But there's no way I could have done that in a kind of traditional approach in that sense. And certainly the time that would not be allotted to me.
So what is it about the model that you've created that allows that time?
Absolutely. And again, this is where I come back to kind of reimbursing. It has to be part of the conversation, right? And so the fact is we charge a membership fee, but that then allows us then to spend more time to kind of focus on things that don't get billed at a face-to-face visit, right? Because unfortunately, with traditional healthcare, you don't get paid until you see someone. There's that face-to-face, and then you bill it, and then that's what you actually get paid for. Any work you do on the side, by the way, and a lot of doctors end up doing it because we care, we want to, and so forth, but we get paid nothing for it, actually. So providing a solution there is to say that let's pay a nominal fee that lets us kind of focus our time so that we don't have to worry about making ends meet, we'll say. But at the same time, lets me focus my time on the areas that I think are important. So I think that's one innovation, we'll say, that our approach allows for. And then it's in terms of
reimbursed at the moment for non-face-to-face.
Mm-hmm.
Is the system allowing reimbursement for non-face-to-face, non-physical face-to-face?
More and more. There's a whole movement towards kind of remote patient monitoring of sorts, which is to say that as we get this data, you don't have to be face-to-face, but you're looking at the data and making decisions off of that so that you can bill a certain amount. The comparative amount that you get from that is still relatively small. So it's still a system that very much encourages a face-to-face visit. But fortunately, we are making inroads in that regard. And I think COVID, if anything, has kind of forced changes in that realm as well. So, but I think the care model design too is again being able to take ourselves away from that face-to-face visit being the way we kind of move forward. Is then we can continue conversation over messaging, right? It can be a continued process. I look at data when things arise. So if you have an issue next Tuesday, we just chat about it. We look at your data. I have all that ported into our systems. But for instance, you don't have to wait 3 months until you see your endocrinologist anymore, right? So overall, it makes for a much more fulfilling experience. And that translates in some cases to just patients being able to, when they're super motivated, to making tremendous progress, right?
Wouldn't it be great if somehow reimbursement or payment was attached to patient experience or patient outcomes? Wouldn't that be a great world to be in?
And there is definitely interest in this kind of like value-based care, as we say, to say that, like look at the outcomes and so forth. And I want to recognize too, unfortunately, that I think that's just a step in the right direction, to be clear. But I think there's certainly limitations there as well. Because let's for an example, let's say for diabetes, for better or for worse, unfortunately, A1C is the metric, right? So if the A1C is lower, below 7, for instance, that's considered controlled. But you and I know if you can have tons of lows and so forth, that average can be lower. And to put it bluntly, I can give someone 1,000 units of insulin, their A1C will look very low, but I'm not treating their disease, am I really? So that's the problem with some of these. You have to figure out the right metric, and it's in medicine, it's often complicated. It's not a simple number you can measure, for instance.
Absolutely. And I think that one of the challenges is that the outcomes are going to be seen in 10, 20, 30, 40, 50 years.
That's it.
And I think and again, back to the system a little bit, but like the system is in the US is a little bit short-sighted, and that short-sightedness actually is just going to compound, and actually it's going to mean that whatever chronic disease we're talking about, because of the short-sightedness, people aren't getting the care they need in the short term. They'll end up in ICU sooner, and the system's going to be more burdened by that. And I don't want to go back to the system, but that's just an example, I think, of what it means to be kind of short-sighted in this sense.
Of course, of course. I mean, there's one statistic out there apparently that people change jobs and insurance, in other words, every 2-3 years actually. So
Yeah.
that speaks to why they're so short-sighted. They don't really care what happens after 2-3 years. So
Well, shareholders have to be appeased.
yeah,
the reporting
exactly.
at all, really, doesn't it?
Yeah, unfortunately.
So yeah, just back to steady a little bit. What are
Please, yeah.
so how long has it been? How many? I won't ask how many patients. That's maybe a bit sensitive, but how long has it been that you've been working with steady?
I started back in about January of 2019. So it's been almost a year, almost 2 years now, essentially. So we're just a month and a half shy.
So enough time to kind of have a bit of experience and to have a bit of an ability to compare, some anecdotal patient experiences that you might have seen through, or what you had seen anecdotally and what you're seeing now anecdotally.
Yeah, absolutely. I mean, for one thing, again, I have the freedom then to focus my intentions where I think it's most important. So, for instance, we actually have a lot of members who are doing really well. They come to us and they're looking for the high tech approach to diabetes, and that attracts them. But let's be honest, their blood sugar is doing very well. We're trying to, we certainly want to help them in what ways we can, but they're doing very well on their own, let's say. But there's others, for instance, that have A1Cs that are 12%, 14%. They have no education on their providers have never taught them about what diabetes even is, for instance. Those are people that we can do a tremendous amount of work for. And, we've seen outcomes, that are very good. And it speaks to the fact that these people are highly motivated, just never had the resources. And for us too, to be able to, shift our resources to those people to really help them and so forth. It's a very fulfilling experience, right? To be able to just turn things around literally within a couple months. So,
and you're doing it. Is it all remote at the moment?
We actually made a decision back in January, predating COVID, to actually go completely virtual. So yeah, it's all remote at this stage. Before that, we did have a physical clinic, but it was trying to figure out what our members were using, and it was mostly telemedicine. And to say that, I think it's, our strengths are certainly that we're so data driven and so forth. So in that regard, it was a natural switch to go telemedicine in that case.
And then if you need more face-to-face care, you just refer on to the appropriate destination.
Right. And so that's definitely one thing that I was very kind of hesitant about. I've always been tied to face-to-face visits, for instance, and losing the chance to see someone, examine their feet, for instance, examine their infusion sites, and all these other things that you can pick up in person, you lose that. And so the trade-off though is that, but then we can reach people all over California, all over Washington, for instance, too. So there's some conscious decisions we made there, and we decided that primary care then can hopefully take the load off there. Right, is to say that, for exams, and more importantly too, if they live 200 miles from me and so forth, if I need to refer them to a nephrologist, for instance, a kidney doctor, their local doctor is their best resource. Actually, I would have no clue who to refer them to. So in other words, they're the best resource in the community. Let us be the resource that we are, which is diabetes.
Yeah, that makes sense. So, just to jump on, I'll start to begin to wrap up, but it'd be remiss not to spend a little bit of time on CGMs, in terms of where we've come from, where we're at, and where you think we're going. Do you want to give us the kind of the endocrinologist perspective on CGMs?
Yeah, I mean, I'm personally a huge proponent. Obviously, I think when you're looking at a couple finger sticks, and I'll tell you when at those older visits, we'll say it's just a bunch of, it's a scatter plot of data, right? Like you have a couple finger stick readings per day, you put into 3 months and so forth, and there's no pattern essentially. Whereas with CGM and so forth, you can actually start to unlock kind of insights on a more personal basis, right? You can actually dive into the day to day and understand that. So I think quantity of data is definitely a big advantage. The fact that you can see trends and reach real-time feedback, right, for the user themselves, that they can see what's going on, incredibly valuable. And of course, predictive alarms too is very helpful too. So in the field of endocrinology, we're very strongly in favor of this in general. So we're making a push for that. The problem, of course, is insurance coverage, costs, etc. do need to improve over time.
Is there any sense of what the percentage of type 1s on CGMs might be anywhere, let's say the US?
Yeah, I mean, I remember seeing a chart, and I know it was dated a couple of years back and so forth, but I do remember there's a jump up in recent years, and I want to say it was something around 38% or so. Don't quote me on that, but it's rising, maybe not as high as some other countries, for instance, but yeah, probably getting in that range for type 1.
Right, that's really exciting. And the differences in the, what would you say there's for Libre, Medtronic, Dexcom, Eversense? Did I miss
Exactly.
anything there?
Those are the four that are currently in
Or,
circulation, we'll say, in the US. Yeah.
a quick good and bad on each of them?
Yeah, well, I think the key things, we can start with kind of like the Libre, for instance.
Yeah.
I think I love that it's the most cost effective, right? I mean, this is something that actually, for people who are, especially new to CGM and so forth, it doesn't cost a lot, we'll say, to try it out and so forth. I think it's convenient. It's not, it's not this big applicator, etc. So it's very easy to use. And good bang for buck, we'll say, and especially with accuracy improving and so forth, that's definitely a big plus. I think Dexcom, I think the big advantage there is, of course, it's continuous feeding the data, right? So the fact that they can see it automatically every 5 minutes. With the Libre, you have to scan, and people forget to scan, for instance, overnight, and so you're going to miss data. And sometimes overnights are critical to understand, basal dosing, etc. Right? Exactly. So Dexcom, I think, has a great thing there, and anecdotally, at least, a lot of patients love the accuracy there too, and so forth. In terms of Medtronic, I think that one is currently kind of in between in terms of unfortunately, it still requires finger sticks, so I think that's one of its drawbacks in that regard. But it does offer a lot that Dexcom does as well, which is the continuous 5-minute data and so forth, and some trend analysis too. And in that sense, a lot of times the Medtronic pumps and otherwise, they're part of a whole ecosystem, so they kind of encourage you to stay in there. So if you love a Medtronic pump, you're likely going to be on a CGM, Medtronic CGM. Eversense is interesting, obviously, because it's implantable. Right now in the US, it's only for 3 months. I know in Europe, it's they're looking at 6 months, maybe trying out for a year at some point. So the idea that you don't have to constantly do that. To be fair, you still have to do finger pricks for now, so it doesn't eliminate that concern. But that's also an interesting approach. But of course, it does require repeat procedures still, and getting people to insert it is actually a harder problem at the moment.
I don't know that much about Eversense. Do you have patients at Steady who are on Eversense?
Very few, and I think ironically, it's I'm not sure. Yes, in some ways, endocrinologists are not necessarily procedure heavy. We do thyroid biopsy, I should say, but we're not really doing like I hate to call it that, but it's like a mini surgery, right? To put it in and take it out, etc. So I think that's maybe a hesitation for a lot of my colleagues.
Gotcha. Okay, so last question. And it comes from hearing in the community, and I did allude to it earlier about, patients wanting to complain about their doctors and blame their doctors for whatever reason. If we're going to flip that around, what are some things that as patients we can do better, or how can we adjust our perspective better to be a little bit more understanding of the job that an endocrinologist or anyone, I suppose, a credentialed diabetes educator or a nurse practitioner, but particularly I think the endocrinologists maybe get the toughest job sometimes when it comes to lack. What's some general feedback or advice or just things that we can think about as patients to help you do your job, I suppose, a bit better?
Sure. I think it comes to a couple of things. Maybe I'll summarize kind of, like one would be simply understanding where we're coming from, like empathy for what we're doing of sorts. And that's simply to say that a lot of times we're trying to get through a day, we want to spend more time a lot of times, but unfortunately our schedules and otherwise are very constraining. A lot of times I think it's understanding that it's not our fault, I think would be really nice. Because for instance, I can't tell you how many times we've been blamed because the prior authorization come through, and then the pharmacy will blame us and then when we talk to the pharmacist, they never sent it to us, for instance. But maybe it's just instead of pointing fingers right away, and simply say, I didn't get this product. Just checking. Did you send in the prescription, for instance? Like just not taking blame, not pointing fingers, etc. Just simply saying, this is what happened. I'm curious what you've done to help me with this, right? I think that would be really, really helpful. I think honesty too. I think, just being honest with your provider, right? Just being, because for instance, there's often a barrier, I feel, and especially if it's, a short visit too, it can feel like that no one's really caring of sorts. But, a lot of times when you actually, open up and talk about your feelings and explain your experience and so forth. It brings us back to why we did join medicine in the first place, right?
Absolutely.
We want to help people at the end of the day. So
Yeah.
I think, being honest about those feelings and just acknowledging them and having an open discussion, I think is incredibly fruitful overall. So those are probably the two I would push the most.
Awesome. I think they're great bits of advice for all diabetics out there. And I can't thank you enough for your time. I really feel like we did just kind of, touch on a number of really interesting subjects. Really appreciate you giving us some time, and I'm sure the listeners really appreciate it as well. Is there anything that you wanted to finish off on, or happy to wrap it up, Kelvin?
No, I think I've enjoyed the opportunity to talk as well, and happy to kind of share my perspectives moving forward too. So I hope this was mutually beneficial overall. So
Really appreciate it. Thank you so much for your time, and have a nice day.
you too. Take care.
Cheers, Kelvin.